Hello, my name is Karen Kembry and I'm a clinical nurse specialist in tissue viability. Anyone in an organisation that cares for people has a role to play in preventing pressure damage. Over the last few years, our local hospital wards have dramatically reduced the number of people developing pressure ulcers. Our incidence has gone from over 14% to now less than 1%. This has been achieved not by the provision of sophisticated equipment or an increase in staff, but by making some simple changes to the way that staff care for patients and changing the culture of the organisation and the way we think about developing pressure ulcers. This presentation will explain the causes of pressure ulcers, describe how they can be prevented, and explain when to seek advice from a healthcare professional, and we'll finish off with introducing the concept of the skincare bundle. When we think of the organs of the body, we often don't think of the skin as being an organ, where in fact it is the largest organ of the body and in most people weighs about 3 kilos. As with other organs in the body, the skin provides a number of very important functions to keep us healthy. The most important one is providing a protective barrier between the body and the environment. If we break the skin, this allows bacteria to invade the tissues and can cause infection. And pressure ulcers can destroy the skin and underlying tissue. As you can see, this is a diagram of a cross-section of the skin. The skin is made up of a number of layers. The top layer is the epidermis, and this is the layer that we can see when we look at our skin. It's a very thin layer, often only measuring 0.1 millimetre in depth. The thickness does vary depending where it is on the body. The thinnest is on the eyelids, and the thickest being on the soles of the feet and the palms of the hand. Below the epidermis is the dermis. This is a thicker layer, although still only a few millimetres thick. And within the dermis contains the important structures for the health of the skin. They contain the blood vessels and the nerve endings and a number of other structures. The blood supply is the most important factor for maintaining the health of the skin. Below the dermis you can see that there's a subcutaneous or subcutis layer, and this layer is made up mainly of blood vessels and fatty tissue. The fatty tissue provides padding for the top layer and helps to protect the body from damage. Below the subcutaneous layer you will find muscle and then bone. So as you can see, the skin is quite complex and has a number of layers, and we need to make sure that all those layers remain healthy for the skin to function and provide that protective barrier. When we talk about pressure ulcers, you may have heard of them as called pressure sores or even bed sores, but through this presentation they will be damage to the skin caused by pressure will be referred to as pressure ulcers. This is a definition of a pressure ulcer provided by a European body. A pressure ulcer is a localised injury to the skin and/or underlying tissue, usually over a bony prominence, as a result of pressure or pressure in combination with shear. A number of contributing or confounding factors are also associated with pressure ulcers. The significance of these factors is yet to be elucidated. When we look at this definition, there are a number of words highlighted in bold, and those are the important words that I want to discuss. A pressure ulcer is a localised area of damage. It's not usually widespread. The damage is small and often round and can be associated with the size of a small clenched fist. It's not like eczema or a spreading infection which covers a large area of tissue. A pressure ulcer is always localised and small, and you will find it over a bony prominence. Now, bony prominences are found where a bone is close to the surface of the skin, and the common areas that we think of might be the hips, the base of the spine, the heels. And the pressure ulcer occurs as a result of pressure or pressure in combination with shear. So those are the factors that can contribute to the development of a pressure ulcer. Pressure ulcers can also be described as an area of damage to the skin and underlying tissue. the damage can range from persistent redness of the skin to a large open wound. And here we can see that pressure damage is not the same, it does vary in severity. Pressure ulcers can be common in some care settings. They are thought of as being common in areas where the elderly is looked after and where people's mobility is reduced. But they can be found on people of all ages and in all care settings, not just in the elderly. If a pressure ulcer does develop, there is a high cost to the patient and to the NHS. For patients, they are painful and debilitating, and if they are left untreated, they can cause serious harm to the person and even cause their death through spreading infection. Treating pressure ulcers costs the NHS in excess of £2 billion a year, and that equates to about 3.8 million per day. So we can see that there's a huge cost to the individual that develops a pressure ulcer, and a huge cost also to the NHS in treating pressure ulcers. And especially this is important to remember when we know that the majority of pressure ulcers can be prevented. And if we can prevent the pressure ulcers, we can save cost to the patient and harm to the patient and save an excess of money which can be spent elsewhere in the NHS. Pressure ulcers are common in some locations more than others, and they can be described as being common below the waist. Places to look for pressure ulcers include the base of the spine, the buttocks, the heels and hips. But there are other locations over the body that are also common for pressure ulcers, and this is where there's a bone close to the surface of the skin. It could be the head, along the backbone, shoulder blades, elbows, ears and ankles. This diagram gives an indication of where you might find those less common areas for pressure ulcer development. Please note that the tips of the toes. This might not be thought of as a common area for development of pressure ulcers, but we do see it, and this is often caused when bedclothes are pulled too tightly over the feet, reducing the blood supply to the tissues. It can also happen when patients slide down the bed and their toes are pressing against the bottom of the bed. So now we know where ulcers can occur, but how do ulcers occur? We've mentioned pressure and shearing, but there's also friction can be involved in the development of pressure ulcers as well. Pressure ulcers are caused mainly by unrelieved pressure. The normal weight of the body squashes the skin and tissues against the bone, reducing the blood supply to the tissues. Normally, we move unconsciously. When we sit in a chair or lie in bed, we don't think about moving, we just move automatically. And this makes people who are unable to move unaided or easily more at risk of pressure ulcers. You just need to think about how many times you may have crossed your legs or shifted from one side to another while you've been listening to this presentation to know that we don't always think about moving, it's done unconsciously. Shear can contribute to pressure damage, and this is where the force of gravity pulls the skeleton down through the soft tissues of the body, and strain forces the layers of the tissue apart, disrupting the blood supply, and this can cause quite extensive damage to the blood vessels near the bone. This can happen when you slide down in a bed or a chair, or are dragged up in a bed or chair using the wrong manual handling techniques. Friction on its own will not cause pressure damage, but where there's friction in combination with pressure or pressure and shear, this can cause pressure ulcers to be more likely. Friction occurs when two surfaces move across one another and can remove the top layers of the skin, making it more susceptible to pressure. And the common areas for this are the heels and the base of the spine. Poor lifting and moving techniques can also cause friction and damage the top layers of the skin. People always ask, how long does it take for a pressure ulcer to develop? Well, there's no scientific agreement because everybody is an individual and we all have different factors which make our risk of developing pressure ulcers different. But the consensus of opinion of experts is that 2 hours of unrelieved pressure will lead to the start of damage to the blood vessel supply in the skin. In those patients who are debilitated, the time may even be less than this again. And there is a high risk in chair-bound patients. People often ask, well, why are people in a chair more at risk of developing pressure ulcers than somebody perhaps nursed in a bed? If you think about it, when you're nursed in a bed, your whole of your body is supported by a mattress usually, and this reduces the amount of pressure over any one point. When we sit in a chair, 75% of our body weight is taken on our thighs and our buttocks. And so this reduces the amount of time needed for pressure to damage the blood vessels. So people nursed in chairs are more likely to develop pressure ulcers than someone who's nursed in a bed. There are factors which make people more at risk of pressure ulcers than others. We need to look at these factors to identify patients that are at risk. Factors that we need to look at are poor general health and increasing age, anything that reduces mobility or restricts mobility, if anyone has a poor diet or fluid intake. Incontinence can cause damage to the skin. Reduced blood supply, especially in the lower limbs, can make heels especially prone to damage. Anyone with a loss of sensation, so they're unable to identify when there's pain or they need to move. And medication can have a detrimental effect on mobility and also on sensation. Body size can impact on your risk, and that can be very thin people where there's lack of bony padding around the bony prominences, or very large people where their mobility may be reduced. There are other risk factors related to people's medical conditions that make them more at risk. These are related to their ability to recognise pressure, so anyone with a neurological deficit or sensory impairment, or where the medical condition makes it difficult to relieve pressure, for example things that reduce mobility. Remember, a major risk for pressure ulcers is where there's a sudden acute illness or a sudden deterioration in their current condition, which causes their ability to move to reduce. Preventing pressure ulcers can be divided into 4 separate categories. And you can see from the slide that we've got skin in red. And the skin is an acronym for the 4 factors you see on the slide here. Skin assessment and care, keep moving, incontinence management and nutrition. And evidence has shown that if we pay attention to these 4 separate factors, we can prevent pressure ulcers from developing. Skin inspection is key. Regular and frequent skin inspection is required for people at risk of damage. We need to take the opportunity to check the skin at each position change and when you clean and change the person. We need to be looking at areas, the base of the spine, the back, buttocks, heels, hips and elbows. Ask the person if there's anywhere that is sore or painful and check these areas as well. Remember, skin condition can deteriorate in a matter of hours. If you see any changes to the skin, you must report these changes immediately to the person in charge for further action. What to look for pressure ulcers? Areas of redness which do not change colour when the skin is pressed is an indicator of pressure damage. On dark-skinned people, we may not see redness, but look for purplish or bluish patches on the skin. You might see some swelling or blisters or shiny areas over bony prominences. Things to feel for on the skin. The skin may feel unusually hard, warm or hot, swollen, tender or moist over a bony prominence or area. In this picture you can see that there's some redness on the heels. When you see redness, it's really important that we're able to distinguish that redness from the first signs of pressure damage, because not all redness will be pressure damage. The way we check this is to do the blanching test. We press lightly on the area of redness for a few seconds, and when we take our finger off, If it's not a pressure ulcer, the skin underneath where we've pressed will be white, and the blood supply then will return and the redness will return. If this happens, this is not a pressure ulcer, but it's not to say that you need to ignore this. Any redness will need to have a close eye kept on it. This slide shows the difference between blanching redness and non-blanching redness. You can see that there's a perspex square pressed over an area of redness on your left, and underneath that perspex, the skin has gone white. This is not a pressure ulcer. On the right, when the perspex is pressed against the skin, the redness does not change, and this is a pressure ulcer. If you see a pressure ulcer, immediate action needs to be taken. To prevent further tissue damage, you need to position the person off the reddened area or damaged area. Check this area again in 30 minutes, and hopefully the redness will have resolved. If the redness does not resolve, you must not put that person back onto that red or damaged area. You need to think about reducing the pressure and reducing the amount of time spent in one position, because that person is more likely to damage skin in other areas also. If the patient is able to move, encourage mobility. If the redness or damage fails to resolve, or it does not blanch, go white when pressed, you need to contact your community nursing team for further advice. The second part of the SKIN acronym is keep moving. Moving is key to reducing the damage of pressure, and you need to reposition the person frequently. It can be anything from 2 to 8 hourly depending on the skin condition. Change the position every 2 hours when in a chair, and this can be as simple as just standing the person up. Use good manual handling techniques to prevent shear and friction damage. When nursing a patient in bed, use a 30-degree tilt for repositioning. Always encourage mobility where possible. Provide written advice on preventing pressure ulcers for people and their carers. Remember that skin integrity can deteriorate in a matter of hours, so keeping moving and checking the skin frequently is essential. The 30-degree tilt is a safe, simple and effective way of positioning people in bed to reduce the pressure over the hips. We need to support the lumbar spine, the lower back, and as you can see here, this patient is sitting fairly upright, and we use a pillow in the base of the spine just to lift the buttocks and position them off that buttock. Use an additional pillow to create tilt, lifting the buttock clear of the bed. Position the legs on pillows so that the heels are over the end and are free of pressure. On this diagram, there is a bolster positioned under the feet. This isn't always necessary, but in this diagram it indicates the position for the prevention of foot drop. Again, you can look at this slide to see the positioning for somebody lying flat in bed, which is very similar to the position I've just described. Sometimes people will have preventative support surfaces to redistribute the pressure and reduce their risk of developing pressure ulcers. These should provide a comfortable surface for the person. There are two types that you might come across. The first is a static system, which is usually made of foam or gel, and this allows the person to sink into the surface and redistribute the pressure. The other type of system you'll come across is a dynamic system, and this actively removes pressure from parts of the body, and often they're filled with air and are plugged in, and they're electric. The important thing to remember if the heels are damaged is to keep the heels free of pressure. Preventative support surfaces will need to be selected correctly following your local guidelines. If a patient is at risk of developing pressure ulcers, use a cushion when they're sat out to reduce pressure over the buttocks and sacrum. When in bed, keep the sheets free of wrinkles and don't tuck them in too tightly, because this will increase the risk of pressure on the skin. Make sure there's no tubing, call bells or telephones lying underneath the person, because again, this will increase the pressure over that area. If the person has got a dynamic mattress and an air mattress, whenever you attend to the patient, make sure that this is functioning properly and that there are no alarms going. Some do's. I've described some do's, but there are some don'ts with support surfaces as well. Don't use synthetic sheepskins to relieve pressure, because these are not effective. Donut rings or water-filled gloves for pressure ulcer prevention will not work. Foam heel dressings have commonly been used, but these give no pressure relieving properties at all. So things like a leave-in heels should not be used for pressure relief. They should only be used where there is a wound on the heel for a dressing. Do not use Kylie sheets, incontinence sheets on dynamic mattresses. These can cause an increase in pressure under the patient and are detrimental to care. Correctly sitting is important. Don't let people who sit in a chair sit for too long, a maximum of 2 hours at a time. Stand the patient up frequently to relieve the pressure. Use cushions on the chair to relieve the pressure. And check, is the chair suitable for that particular patient? Is it the right size and the right height? This is a picture of a correct seating position and an incorrect seating position. If you look to your left, the student nurse is sitting correctly. She's well supported on the chair, she's upright and her heels are free of pressure off the end of the stool. But you may position your patient correctly, but you turn round, look back, and what you will see is the picture on the right. The person has slipped down the chair and they are no longer in a good position and causing pressure on points on the back of the head, on the elbows, on the back of the spine, the buttocks and the heels. So we need to be checking the patient is sitting correctly in the chair to prevent damage. The third point in the skin acronym is incontinence. We know that wet skin can become fragile and easily damaged, and if patients are incontinent and this isn't managed properly, you can get damage to the skin. Offer toileting regularly. Make sure that they have the ability to go to the toilet. They've got a call bell or they're able to call you when they want to use the loo. If a person is incontinent and they're using continence products, make sure these are well fitting. They're not causing damage around the legs and that they are fitting close to the skin. A bone of contention is often the fact that people use zinc-based creams, for example Sudocrem, with continence products. Don't use this with continence products because it blocks the pads and reduces the efficiency of the product. Use creams that are produced especially for continence products such as Cavalon or Conatrin. Wash the skin daily or when visibly wet or soiled. Use moisturisers for dry, fragile skin, and if you wash the skin frequently, use a soap substitute, for example Diprobase or Epiderm, to wash the skin and protect its natural oils. The last part of the skin is nutrition. Good nutrition and hydration is essential to keep the skin healthy. Respect people's dietary preferences. Try and give them what they would like to eat, because we know this encourages a good nutritional diet. Assist those who need help. Make sure that you help when the food is delivered, that the food doesn't go cold. Monitor food intake and hydration. Notice if people are not finishing their meals and report it. Offer drinks when appropriate whenever the person's position is changed, because hydration is very important to keep the skin healthy. If you notice that food and fluid intake decreases and is of concern, contact your community nursing team for further advice. We've just gone through the 4 elements of preventing pressure ulcers: skin assessment and care, keeping moving, incontinence management and nutrition. If a pressure ulcer does develop and you have concerns regarding any of the above, contact your community nursing team for advice. The community nursing team has expertise in preventing pressure damage, and a registered nurse can examine the patient and undertake a risk assessment to determine the person's risk of developing pressure ulcers. The risk assessment will identify specific factors that make that person at risk. She will then develop a plan of care to help prevent the development of a pressure ulcer or heal an ulcer that has developed. This plan will be discussed and agreed with the patient and carers and written into the care records. And this plan will be reassessed if there is a change in the condition or circumstances. If necessary, the nurse will implement a skin care bundle. So what is a skin care bundle? Well, a care bundle is a group of interventions related to a disease or condition which, when carried out together, will improve care outcomes. The skin bundle, we've already talked through, contains 4 essential elements: skin inspection and skin care, keep moving, incontinence management and nutrition. And we know that if we pay attention to these 4 factors, we can prevent pressure ulcers from developing. We also need to assess each individual for ongoing risk. If their condition changes, we need to assess whether that makes them more likely to develop pressure ulcers. And of course, training is important because we need education and understanding to be able to implement these skin bundles. Who needs a skin care bundle? Well, not all patients or people will need a skin care bundle, but anyone who has an elevated risk of developing a pressure ulcer will need a skin care bundle, and anyone who has a pressure ulcer will also need one. Now, this is a very busy slide, and it's a picture of a community skin care bundle. If one of your patients or a person in your care is put on a skin bundle, the nurse implementing this will go through the skin bundle and explain all the elements through it. Because you will be involved in filling in the skin bundle if one is appropriate for a person in your care. Because anyone who is providing care and observing the skin will be able to fill in elements of the skin bundle. We must remember that the factors must be ticked and initialed. It must be completed in full, and at regular intervals will be inspected by a registered nurse. By following the guidance in this presentation, you will be able to prevent the development of avoidable pressure ulcers. The community nursing team will keep a record of any incidences of pressure ulcers developing in your care, because we have a zero tolerance to the avoidable pressure ulcers. So in summary, nearly all pressure ulcers develop as a result of inadequate preventative care. Early signs of damage are often not acted upon quickly enough to prevent the progression of damage. People are at high risk when their ability to move, feel pain or communicate is impaired. We know that equipment is very valuable in aiding patient care, but is no substitute for high quality care. And following the principles set out in this presentation will minimise avoidable skin damage. Remember, skin assessment and care. Keep the patient moving, manage incontinence, and make sure there's good nutrition and hydration. Prevention is always better than cure. Have a zero tolerance to pressure ulcer development. The next 4 slides contain graphic images of ulcers, some of which you might find upsetting. You may choose not to view them. Pressure ulcers, as I said at the beginning, can vary in severity, and we grade pressure ulcers from category 1 to 4. Category 1 is the start of pressure damage, and this is where you get intact skin with non-blanchable redness over a bony prominence. On darkly pigmented skin, we may not have visible branching when you press the skin. But the other factors we need to look out for are discoloration of the skin, warmth, oedema, hardness or pain may also be present. Category 2 is where the damage starts to extend through the top layer of the skin into the underneath layer of the skin. This is partial thickness loss of the skin, and it often presents as a shallow ulcer or a blister. And it can have a red-pink wound bed, but there is no yellow or black tissue within the wound. Category 3 is a full thickness pressure ulcer. Fat may be visible, but bone, tendon or muscle are not exposed in the wound bed. Some yellow tissue or slough may be present, as you can see in this picture here. The most extensive damage is category 4, and this is where you've got full thickness skin loss, and you may have exposed muscle, tendon or bone in the base of the wound. Yellow or black tissue may be present. The ulcer is often bigger than the opening that you can see and often extends underneath the skin. Well, thank you for listening to the presentation. I hope you found it useful, and it will hopefully inform your practice and lead to an effect where we reduce avoidable pressure ulcers.